to this DXRX Lab Talk, hosted by Diaceutics. Diaceutics provides end-to-end solutions for the launch of precision medicine diagnostics. Using our platform, DXRX, the diagnostic network, we place labs at the forefront of developments in the precision medicine landscape. Our mission is better testing, better treatment. We believe that labs need to be involved earlier in the precision medicine decision-making process. We promote partnership and education to drive precision medicine, and the work of laboratories remains central to this mission. DXRX membership is free of charge and provides access to our aggregated datasets, the latest reports, publications, and lab talk recordings, and ensures you're the first to hear about scientific studies and DXRX collaborations, such as EQA programs, grants, and global ring studies. Since 2020, we have executed over 30 collaborations covering a range of purposes, some of which have resulted in publications or posters at major conferences. Visit dxrx.io to learn more and register for upcoming lab talks and collaborations.
Hi everyone, and welcome to the DXRX Lab Talk today, focusing on a multidisciplinary approach to HRR testing in prostate cancer. So let's jump in as we're on time today. So definitely looking forward to engaging in this topic and conversation with you. What I'd like to do is just remind ourselves of the objectives of today. So this lab talk brings together an expert panel to discuss and share their points of view regarding the current approach to HRR testing in metastatic prostate cancer, where we'll understand the challenges experienced today with activating a HRR test during the prostate cancer patient journey and explore the evolving role of ctDNA in supporting HRR testing. So I'm happy to have our expert panel here today as they discuss real-world scenarios and how their institutional multidisciplinary approach has improved test activation for their metastatic prostate cancer patients. So this session will really highlight how a collaborative approach between a multidisciplinary team can be used to improve patient outcomes. So with that, just to introduce myself, who will be moderating today. My name's Kevin Entwistle. I'm VP of Scientific and Advisory Services here at Diaceutics. I come with nearly 20 years experience in precision medicine, working on the diagnostic side as well as the pharmaceutical side. So looking forward to the conversation. Let me introduce our expert panel today. So we have Dr. Barberis as well as Dr. Attard joining us. And I'll hand over to them to provide their introduction. So first of all, Dr. Barberis, if you would like to come off mute and introduce yourself.
I am a pathologist. I am currently senior consultant of the Division of Experimental Oncology and the Department of Advanced Molecular Diagnostic at the European Institute of Oncology. And I was formerly director of the Histopathology and Molecular Diagnostic of the same institute. It's a pleasure to be here with you. Thank you.
Thanks so much, Dr. Barberis. And Dr. Attard.
Hi everyone. My name's Gerhardt. I'm a medical oncologist and clinician scientist at University College London in the UK. I'm the director of the UCL Cancer Institute, and I run a lab-based team and a clinical team focusing on the treatment and patient stratification of metastatic prostate cancer. I've, I guess, done a fair bit of work on molecular analysis, so looking forward to a good debate.
Great. Thanks, Dr. Barberis. Thanks, Dr. Attard, and definitely looking forward to the conversation ahead. So if we just look at what our agenda is for the next 50 minutes or so, what we want to do is just provide a high-level overview of HRR testing in prostate cancer, looking at the sample material, sample testing, as well as that overarching testing process, some of the complexities there, and then really looking at the reporting of those results. The main body of today really is focused on the roundtable discussion with our panel. So bringing together the pathologist as well as the oncologist in terms of how we manage metastatic prostate cancer patients today. Then we'll open it up to Q&A from our audience. So just a reminder to our audience, within the Teams app, there is a Q&A tab. So please feel free to enter questions throughout the time as they come up, and we will look at those at the end and engage with Dr. Barberis and Dr. Attard. So first of all, really thinking about precision medicine in prostate cancer around HRR testing. So looking at the clinical relevance of testing HRR mutations in prostate cancer, including BRCA1 and 2, is multifaceted, with high prevalence of different HRR genetic alterations. So HRR can help inform clinical and treatment decisions in a number of different ways today, whether that is in terms of hereditary risk, prognostic value, or to aid in targeted drug therapy decisions. So HRR is a DNA damage repair mechanism. So this is including a number of different genes that is inclusive of BRCA1 and 2, but includes a number of different genes as well. So deleterious HRR gene mutations really lead to an inactive HRR pathway and potential cell death via unrepaired DNA strands. When we look at the frequency of these different variants, what we can see is BRCA2 is obviously the most prevalent, and our other HRR mutations make up the remaining variants that we do see. So what we often see is patients often carry germline mutations linked to hereditary risk, but we also see somatic mutations in BRCA and other HRR genes. So we do find approximately 20 to 25% of metastatic prostate cancer patients have germline and or somatic HRR alterations. When we look at the prognostic value of HRR, what we do see is that impact of BRCA positive or the HRR positive non-BRCA, and then versus the non-BRCA, that these patients have potentially worse outcomes and leveraging HRR variants as that prognostic marker. The other thing that we use HRR for is that predictive value. So we do have targeted treatments available for metastatic castration-resistant prostate cancer patients in terms of the PARP inhibitors. And so by conducting a HRR test, a biomarker test, what we can do is identify those patients that are positive who may be eligible and may benefit from these PARP inhibitors therapeutics. What we do see in the guidelines is a few different approaches in terms of the specificities. However, they all align on the need for testing in this disease setting of metastatic castration-resistant prostate cancer. The specific genes that are recommended do differ on guidelines. So what we do find is that there is not necessarily a consensus today on which genes to test, but definitely a push towards testing for these patients. There's also a bit of differentiation in terms of when to test, as well as sample materials for testing. And I look forward to discussing that with the panel in a bit more detail later on. When we look at the prostate cancer patient journey, so as mentioned, we do have testing built in there. The guidelines are supportive of it. The key thing we want to highlight today and really focus on is this multidisciplinary team approach. So the stakeholders that we have today with us are the medical oncologist as well as that pathologist. But what we do need to remember is that there are others involved in this, with the urologist playing a role as well as the genetic counselor. And again, looking forward to exploring that in more detail with our panel. If we move into the patient journey itself, so first of all, thinking of sample testing, what is that sample material that we do want to be using? and what is relevant. So thinking of both somatic testing and germline testing, what is that sample material? So when we think of different sampling methods, we've got a number of different biopsy types that we can use. If we group it into two buckets, it's primarily tissue-based or liquid biopsy. And all of these have different pros and cons. What we acknowledge is that tissue has typically been the gold standard for biomarker testing and remains that way. And so there's certain things that we need to acknowledge and understand in terms of the challenges that come with tissue testing, but also be open and understanding of the potential for liquid biopsy with ctDNA to enable patients to be identified for HRR variants. So being able to understand these testing challenges and some of these standardized practices for sample collection and processing can really increase tissue availability and improve access to HRR testing. So these critical things are obviously the amount of tumor tissue, so that initial collection of the biopsy and being able to have enough material for the standard routine diagnostic testing, but also enable biomarker testing for that prognostic or predictive purposes. The pre-analytical factors, so again, that specimen type and looking at the age of that specimen. So what we do have in prostate is commonly use of archival tissue, excuse me, archival tissue for testing. And so the age of that the age of that tissue and the quality of the nucleic acid that we get from it can be compromised if the tissue is several years old. When we look at the organ site, so again, thinking around when we're taking that sample, where we're taking it from, we look at prostate cancer and the common metastases is to the bone. A sample from the bone has its own potential challenges in terms of the quality of nucleic acid that we get from this material, primarily due to the decalcification process. So again, we need to take into consideration these items, these steps, throughout that tissue processing to ensure that we are going to be able to get a valid result from our sample material. Also looking at that repeat testing. So this is where we do get a little bit of difference in guidelines on when to test. But ultimately, should we be repeating testing as these patients progress through stages of disease, through metastatic prostate, from hormone sensitive to castration resistant? And how and which material should we be using? At the end of the day, no sample type is perfect, and there's pros and cons to each of them, whether that is archival tissue, fresh tissue from metastases, or whether it's from ctDNA. I don't plan to go through a lot of this detail, but again, conversation that we look to explore in terms of the accuracy and reliability of these sample materials and some of the considerations that we need to take into account when we are looking at HRR testing. The one piece on ctDNA that I would like to highlight is we do have a number of clinical studies that have demonstrated concordance and high concordance between tissue and liquid. So liquid biopsy definitely has its place in prostate cancer, although it might not be routine today. We want to explore where the role of ctDNA is and where it can benefit in terms of finding those patients that could benefit from targeted therapies. When we look at the actual testing process, so the guidelines do recommend testing for HRR mutations in prostate cancer, but that testing approach can be different. So whether that is on single genes, such as BRCA1 and 2, or whether it's on broader panel testing. So thinking about HRR testing and how to test, the single biomarker testing can be very limited in terms of we are only looking at BRCA1 and 2. As we demonstrated before, there are broader genes of interest for HRR, and that frequency does vary. So obviously BRCA2 being the most common, but we also need to think about the ability to detect the other HRR mutations and variants. Going to the right, obviously we look at NGS panels, and these can be small focus panels, or broader panels that include a number of different genes. We also then go into the whole exome sequencing, whole genome sequencing. Although we don't see this in routine clinical practice today, these technologies obviously enable a comprehensive view of a patient's genome and being able to direct or gain information that can then direct therapeutic and clinical decisions. We do also need to acknowledge some of the limitations here, especially in terms of the variant types within the HRR genes and the pros and cons to each of these methods. Ultimately, what we want is the method that is going to maximize that patient identification in terms of finding all the relevant HRR variants that are of interest. Lastly, what we think about is the reporting of those results. So those results need to be reported in a concise, clear, and standardized manner that enables the treating physician to make that appropriate decision for our patient. We did have a publication last year from ESMO that put some very clear recommendations on clinical reporting of genomic results in solid cancers. This paper had a few different recommendations in terms of the structure, where we would have around the assay features, sample characteristics and quality parameters, the genomic findings with functional annotation, and really that clinical actionability. They did have some recommendations around summarizing those key messages, including estimations of tumor content, which is very critical for ctDNA, but also for tumor. The strong recommendations to include clinical interpretation of findings, but not necessarily that treatment recommendation, and strong recommendations to identify any need for follow-up or confirmatory tests. Also, being able to avoid clinical annotations of variants of unknown significance, or even avoiding the VUS in its entirety. So I look forward to discussing some of these points with our panel over the next few minutes. But in summary, some of those key messages that we have from the current state is looking at HRR mutations are associated with poor prognosis and potential benefit from treatment with PARP inhibitors. Biomarker testing on tissue samples should be performed to identify HRR mutations and metastatic disease and reflex the germline if it's not already performed. ctDNA testing can be considered when tissue testing is not possible, but it's viewed as a complementary technology today. Different methods and assays are available to identify somatic and or germline HRR mutations, each having their pros and cons. And then ultimately, that multidisciplinary team collaboration is critical for enabling optimal HRR gene testing and successful management of prostate cancer patients. One thing I would just like to highlight, so Diagnostics are launching a website that contains a lot of the material we've discussed so far, as well as additional material around HRR testing in prostate cancer. This website is due to launch soon, and details will follow where you can access this information. It is also going to be somewhere that this webinar is going to be hosted as well. So with that, I'd like to move into our roundtable discussion and engage with our panelists, Dr. Barberis, as well as Dr. Attard. So moving on to our questions. The way that I'd like to structure this is thinking first of all of this current state. What is the current state today and how are you performing and managing testing for your metastatic prostate cancer patients? So Dr. Barberis, I'll start with yourself. What do you see as those current challenges for HRR testing today in your practice?
Thank you for your presentation and for your questions. I think that now we have considered that there are many barriers to the access of HRR testing, and the barriers are similar to other NGS testing because they depend on the the healthcare system, the geographical areas. The first barrier is the cost, because in many areas the patients must pay directly, and they say is not reimbursed. The patients may have private insurance or pharma sponsorship. The second barrier, you have told this before, and I would like to spend some words on this, is the quality of the sample, the insufficient samples, the poor quality of the samples due to pre-analytical or analytical procedures, the geographical access to specialized labs, and at the end, some clinicians are not completely aware of the most recent guidelines published by scientific societies. So, as you told before, many genes must be evaluated. Even few of them have a true predictive value, for example, CHEK2, and apart from BRCA2 and BRCA1. NGS should be the method of choice. However, we have to consider the many biases. The first is related to the quality. In the profound trial, a phase 3 prospective biomarker selected trial involving patients with metastatic castration-resistant PC, only the 57% of the samples could have been sequenced with NGS for the poor quality of the sample or the scanty quantity of the tumor cell present within the sample. As you know, after this trial, olaparib was approved for treatment of this tumor in men with mutation BRCA1 or 2, in whom medical or surgical treatment did not work and whose cancer worsened after treatment, for example, for new hormonal agents. In Italy, in a multi-center study performed in 8 referral centers, we showed that the definition of BRCA status in FFPE samples, both surgical samples than core biopsy, with more than 5 years of archive, we obtained a result in 30% only of the samples. The problem is that tissue samples from prostate tumors are taken from, I think, almost all patients at the time of the diagnosis, and the time to progression to metastatic castration-resistant tumors can spend years, causing the high failure rate of NGS. How to overcome this problem? I think that there is an expensive solution. For example, at the time of diagnosis, the pathologist could select an adequate sample, extract nucleic acids, and maintain at minus 80 degrees Celsius an Eppendorf tube tracked with a biopsy number or the biobank identification number. Another problem to consider is that sometimes the greater rearrangements or duplication in BRCA tests may not be detected, mainly if we work with amplicon-based technology. Hybrid capture chemistries can reduce the problem, but I think that a parallel germinal test could eliminate this problem. This is, in few words, my opinion on your question. Thank you.
Thanks, Dr. Barberis. Appreciate the perspectives there. And Dr. Attard, same question. Like, what do you see as those current challenges today?
Yeah, I agree with all the comments Dr. Barberis made, Massimo made. So, cost, tissue quality, access to labs, education. I'll add to that the human power to retrieve the samples. So that's actually what's the biggest challenge in my practice. Who's going to chase up the sample, coordinate, get it sectioned, show it to the pathologist, who's going to mark the area with highest tumor content, and then chase the result, make sure the result gets to the physician in clinic. And what works here are dedicated coordinators. and that has a big impact. But that costs money, of course. And cost was the first challenge Massimo mentioned. But yeah, it's finding someone to coordinate all of this. And then, the quality of the tissue, and I agree, if we tested samples when patients were diagnosed, especially if they're metastatic, then I think in the long run, that will save us cost. But when I debate that with my payers, they say, oh, that will mean a lot of patients being tested unnecessarily. Or, Massimo made an intriguing proposal, just extract the DNA, keep it in the freezer, but that comes at a cost as well. And because the license for PARP inhibitors currently is for mCRPC, payers are not convinced that all MHSPC patients will develop mCRPC and be in line for a PARP inhibitor. But I have the same opinion that testing up front will be good for patients and good for the healthcare system. And I think it's certainly something we should strive towards. So reflex testing at diagnosis, implement the tests. Now, Massimo mentioned 57% success rate in PROfound, which ours is slightly higher, not much higher, but slightly higher success rate for obtaining a result. Of course, in PROfound, that was a time where bits of tissue are being shipped to the US. So I was intrigued to hear that actually in the Italian study referred to, it's even lower. But that really emphasizes the challenges of sequencing samples later on. Yeah. So we're broadly aligned, but the main thing I've added is, a person who's going to coordinate all this. Because in a busy oncology clinic, who's going to, vast majority of physicians are too busy to be chasing tumor samples, making sure the pathologist can see it and then getting it to the lab and then chasing the result.
Yeah, no, thanks, Dr. Attard, and again, appreciate those views, because I think it's leaning into the topic that we're wanting to discuss, which is really that multidisciplinary team approach, right? But there's only so many people that will sit at that table within those meetings, but acknowledging that there is a broader team supporting in order to enable this for the patients to get tested and ultimately treated. Mm-hmm. One thing, just to touch on what you're saying there. So the ideal is test at metastatic diagnosis. Then we can use that result further down. This is where some of the guidelines differ in terms of that testing, when to test. We have some international guidelines like NCCN that are recommending a metastatic diagnosis. We have others that say at metastatic castration-resistant diagnosis. So how do you approach it in your practice? Because obviously you're in the UK, you use different guidelines like NICE instead as well. How's that influencing your practice today in terms of when you're testing, how you're testing?
Yeah, so NICE restricts, so NICE covers the drug approval. And then once there's a drug which is recommended for funding for an indication, then the National Health Service draws up test lists or directories of tests that can be used, and that would be funded. And currently, the funding is very specifically for BRCA only, so BRCA2 and BRCA1, for patients with mCRPC progressing after an ARP, an androgen receptor pathway inhibitor. But as we've both implied, that is highly inefficient. And several other jurisdictions and practices are a bit more flexible and taking advantage of testing at MHSPC. Specifically to your question, and we've highlighted some of the challenges, Kevin, that we are considering a patient for testing when they are starting to progress on an RP. So abiraterone, enzalutamide, apalutamide, or darolutamide. And that's when we set the ball in motion to request that tumor sample, bring it in, and have testing done.
And Dr. Barberis, like in your practice, like from the lab perspective, what does that test request look like? Like, is the physician, are they ordering BRCA 1 and 2 only? Are they requesting HRR? Are they ordering NGS? How does that request look to you in the lab? And then how are you actually conducting that test?
Yes, in my experience in our institute, a part of the pathologist's work for the definition of histological type, Gleason's and ISUP grade, the extension of tumor and biopsy or surgical samples, whereas the molecular pathology lab is engaged in metastatic castration-resistant BC only. In this patient, we are required to detect somatic and or germline BRCA1 and BRCA2 pathogenic variants only. The patients have previously received docetaxel sequentially with an ARSI drug and did not previously receive a PARP inhibitor. Only in this case, the treatment with a PARP inhibitor may be considered. Currently, in Italy, the only PARP inhibitor reimbursed is olaparib. In our institute, the testing requests are made by the oncologist and not by the urologist. We perform, because we have discussed this problem with the oncologist, and we perform a targeted sequencing of homologous recombination repair genes to reveal the underlying cause of HRD and utilize a commercial deep learning algorithm coupled with a low-pass whole genome analysis to measure genomic instability as a result of HRD. So we offer a mutational profile of genes involved in HRR and offer a genomic instability index. In other terms, we measure HRD for prostate cancer with the same assay that we use for ovarian, for a high-grade serous ovarian cancer, or when it's called for triple-negative breast cancer. This is our approach.
Right. No, thanks, Dr. Barberis. I think that talks to the one thing within labs, like when we have moved away from one test for one purpose and being able to leverage these panels across those indications where it's relevant, and which it sounds as though within your practice, that HRR, HRD panel is being leveraged across multiple indications.
Yes, because the problem is that in this way, we could candidate our patient, for example, to clinical trials, and this is an opportunity for them, or to study better the germinal impact of the somatic defects that we found, especially if we consider that in our report, the variant allele frequency is a very important parameter for the oncologist to try to submit the patient, for example, to a genetist.
Thank you. And Dr. Attard, obviously you mentioned like the genomic directory in the UK is only funding BRCA 1 and 2. Like when you're actually getting these patients, like what biomarkers are you requesting and getting? Like is it focused only on BRCA 1 and 2, or is a broader test being performed?
Yeah, it's interesting because the test that's performed in most of our they're called genomic lab hubs is a pan-cancer panel with 300-400 genes, and there's the same test which is done on prostate patient, a lung patient, breast, etc. But then for a prostate patient, only BRCA is reported. The sequencing data is there, but that hasn't been looked at and signed off by the biomedical scientist or reporting physician, reporting scientist, clinical scientist. So currently the information I'm given related to BRCA1 and BRCA2. Information I would like to have is CDK12, especially for PARP inhibitors, PALB2. There's a number of other HRR genes where I guess if funding or other mechanisms allow, I would use a PARP inhibitor. So yes, and it's not going to cost much or be overly cumbersome to expand the number of genes information is provided for, because that data's there. It's just there's a slight increase in cost, and I hope we'll start to see more of that information being provided in our reports.
Right. Thanks for that insight. I think what we're hearing from both of you is that testing approach is definitely broader than just BRCA1 and 2. We're hearing obviously either a targeted panel or a broad panel that's inclusive of multiple genes. The piece then is really on how that's being reported back to the oncologist and ultimately used, and hearing some of the limitations there in terms of how things are funded that enable that reporting. But I think we can all acknowledge that the value is there in doing more broad, comprehensive testing to identify those variants in HRR. So with that, I think, Dr. Attard, I'll start with yourself. How are the multidisciplinary teams working within your practice? How are you engaging with your pathologists, with your urologists in the management of these patients?
As I think similar to the scenario Dr. Barberis described, it's oncologists who are ordering the test, or at least it's doctors who prescribe PARP inhibitors. And the majority are oncologists, although there are some urologists who do treat metastatic disease. It's really not so much dependent on speciality, but dependent on one's practice and what one is doing. So we order the test and we liaise closely with our pathologists for organizing and receiving the results. As a pathologist who will review the sample and then send that on to for testing. The urologists currently are not involved in that direct process in MCRPC, although there are two really important points, at least 2 important points that we need engagement. Firstly is if we need to rebiopsy a patient, either because the tissue can't be found or the tissue fails. And our urologists here are very supportive of that and support us with that. And the second is in the original biopsy. And the more tissue that's obtained at diagnosis, and the more carefully it's processed, the greater the chance of success down the line. So investing in the future, that's where that is a really multidisciplinary team effort, which the urologist who's taking the biopsy and counseling the patient, it's a pathologist who's processing and the custodian of that tissue, and there's the oncologist who will be ordering the test, and the three of us, though in many others, are key to getting that result.
Thanks, Dr. Attard. And Dr. Barberis, how is the multidisciplinary team approach working in your institute?
So in other terms, you ask me which biomarker I could request for this patient. In part, I answered before to these questions and fully agree with Gert that the best reason of success in treating a patient with this tumor is a shared procedure of the multidisciplinary team. I would like to underline how globally more than 10% of the patients with metastatic prostate cancer are carriers of germline mutation in at least one of the genes involved in DNA repair. It is true that the main part of them have alteration BRCA2. But in more than 20% of metastatic neoplasm, there are somatic mutation only. And more than 40% of these patients have somatic BRCA2 mutation. And the mutation is the same in the tissue and the same at the germinal level. So this is very important to have this impact on the germinal part in mind. Moreover, the patients are few, no more than 3-4%, but we suggest to test even the expression of MLH1, MSH2, 6, and PMS2 genes. The lack of expression, apart from the case of methylation of MLH1 promoter, suggests the need of a germinal test to exclude a Lynch syndrome. And patients with mismatch repair deficiency could be theoretically candidate to immunotherapy. I would like to know the opinion of Gert about this. So with this evidence, it seemed reasonable to investigate the presence of, in the same patient and these family members of this alteration at an anamnestic level to highlight any hereditary syndrome to involve, I can say, high risk of cancer and to suggest a genetic counseling. This is my opinion. And as I told before, I would like to have the opinion of Gert.
Yeah, mismatch repairs, it's a real tricky one that I'm really torn by, because until recently we had a lot of trials of immunotherapies and some axis, and we were extensively doing mismatch repair testing with immunohistochemistry. As Massimo said, it's easy to do, cheap to do. It's done in well established for colorectal cancer. So our pathologists are very comfortable with that. And there is loss in 1 to 2% of our patients. We're finding it harder to access immune checkpoint inhibitor therapies for our patients, and the cost is high. It's not currently funded, but I agree this should be standard of care. And hopefully overcoming the funding limitations. Funding limitations aside, every patient should be tested, because when I have treated patients with mismatch repair deficiency and an immune checkpoint inhibitor, that's an opportunity we shouldn't miss. The trials are out there, and we will have experiences of patients having complete responses. So it's certainly worth doing, I agree.
I appreciate that. I think, yeah, that talks to that comprehensive testing approach for these patients to identify all possible treatment options. I'd love to probe more, especially around MSI versus MMR, and obviously MSI being within panels, but the conversation for another day on that one. Just keep us moving in terms of like future state. So right now we have a number of drugs already approved in metastatic CRPC. We may not have them approved locally for reimbursement, but we do have the actual drug approvals. We obviously have a number of different studies going on that are looking to move these drugs into earlier stages of metastatic prostate cancer with the hormone sensitive area. So what do you see as the evidence needed to change that clinical practice today, or in the future, sorry, to ensure that every metastatic prostate cancer patient receives appropriate testing? And again, I know we've alluded to some of these through the conversation, but Dr. Barberis, your thoughts on what we can do to improve and get more access to testing for these patients, especially as we move earlier in the disease?
So I think that probably in the future DNA profiling as a part of screening strategy will be used with all the problem of cost that are related to this procedure, that it was very well underlined by Gert. If for a wishful thinking, I would like to say that we have learned from clinical trials that the high variability in clinical response among patients with different HRR gene alteration. Even among patients with BRCA2 defective prostate cancer, the stronger predictor of PARP inhibitor sensitivity, response rate in clinical trials range from 40 to, I think, 60%. And this suggests that a proportion of these patients do not achieve a clinical response. Gert, correct me, please, if it is not correct. Therefore, I think that there is a need to refine the biomarker strategies to improve patient outcomes. We are talking about future. The study of genomic signature, the so-called scar of the tumors, such as LOH score, large scale transition, telomeric allelic imbalance, that are three bioinformatic parameters that form an algorithm to define a status of genomic instability of this tumor, has been shown with a potential predictive value in ovarian and breast cancer. But the clinical value for prostate cancer management, I think, at the moment remain controversial. Apart from a small cohort of patients with the BRCA2 associated with 53 mutation, there are some studies about this. But recently, an immunofluorescent-based assay has been optimized to allow the study of the RAD51 foci in FFPE samples. So the protein RAD51 is a recombinase, the key component of homologous recombination. And so in response to double-strand breaks, RAD51 form foci at the site of the DNA damage that we can visualize by immunofluorescence. And so in other terms, this is a proxy to evaluate the efficiency of this pathway. And this could be another tool in the future to have best information, to have a better strategy to improve the patient outcome.
Thanks, Dr. Barberis. And Dr. Attard, your view on what needs to change?
Yeah, so I agree. In fact, Attard, the first point I'd made and scribbled here in answer to your question, Kevin, is not all gene alterations are the same. And it's exactly what Massimo said. Response rate 60%, even in a selected population, and that durability of response is variable. So, we need better databases of all the alterations because they are not recurrent. There's this high complexity, and often labs are seeing mutations that they need to predict on whether they are pathogenic or not. So as this data becomes more extensively shared, that will improve our understanding. And probably BRCA is reasonably well understood, but the other genes involved in homologous recombination repair that are less, where alterations are less common, we're going to have to really work together and set up those databases to better select patients. The alternative is a alternative test, which looks for scars or looks a functional test like RAD51 that Massimo described, although they do remain challenging. They're mostly, I mean, it's been a lot of research. We said we're not using these in clinical practice, and partly related to variability. So actually implementing and having a reproducible result. So yeah, there's really good data for the benefit of PARP inhibitors with large trials. We have a multitude of large prospective clinical trials with randomization, so we can understand the efficacy of the treatment in different molecular subgroups. I don't think we need more information added there. I mean, more information is always, oh, he's good. But there's very strong evidence now. It's how do we share information as we build our clinical practice, our clinical experiences, because we are seeing very small numbers of specific mutations, even within large practices. So we need, we need to use platforms to share that. The second is studies that show better ways of analyzing samples. So be it white papers, sharing of protocols, studies that identify ways to improve the success rate. I think that will help at a ground level.
Right. I think that key message here from both of you is we need to ensure that we're testing appropriately in order to enable all of this. And that is, how do we use this information to manage these patients moving down? So just conscious of time, we've got about 10 minutes left. One of the key questions I did want to ask both of you is, how do you see the role of liquid biopsy changing in prostate cancer? So the use of ctDNA. Dr. Attard, maybe let's start with yourself.
Yeah, and I have a bit of a disclosure here that my lab studies liquid biopsies. So I am biased, but I have to emphasize a challenge with liquid biopsies, that the tumor fraction is often low. What that means, so when we're analyzing a tumor sample, we're looking for at least 30% of that being tumor, whilst in a liquid biopsy, we're often dealing with 3 or 4% of the nucleic acid material we obtain there arising from tumor. And that introduces two challenges. The first is false negatives. So a report comes back and the patient has not been found to have a BRCA mutation at a somatic level. So germline will be detected because that will be always detected in a blood sample. But if it's a tumor-only alteration and there is insufficient tumor for the test to call it, the patient will be labeled as negative. So what I always insist is, based on the liquid biopsy, don't label your patient as BRCA negative unless you know there were high tumor levels in the liquid biopsy. So false negatives and also missing certain alterations such as deletions, which require higher tumor levels than mutations, which can be called at levels as low as 3 to 4%. And this problem is going to, or has become, more of a challenge as we've used PARP inhibitors earlier and earlier in the disease paradigm. So when I first started using PARP inhibitors, it was for patients who'd received an RP for CRPC, then received 2 or 3 lines of chemotherapy. And that's when we're testing liquid biopsies. But now we often will use a PARP inhibitor or consider a patient for a PARP inhibitor much earlier on. And then the tumor fraction is lower. So the chance of a false negative is larger.
I appreciate that perspective. And Dr. Barberis, like, your view on ctDNA moving forward?
Yeah, I fully agree with Gert, and I see that he gained a lot of experience with liquid biopsy. In fact, we expect that ctDNA testing will increase for patients with this disease because it offers the convenience of testing on a blood sample in advanced setting. We know from different studies that the efficacy and the safety of PARP inhibitors were consistent between patients whose alterations were identified by ctDNA and NGS testing, and those whose alterations were identified by tissue-based testing. I think that we have in front of us a great progress because in modern ctDNA testing can be a reliable alternative to tumor-based testing. And the parameter that Gert discussed before, the tumor fraction, is of pivotal importance. There are unfortunately few commercial tests that give us the information of the tumor fraction, but there are other tests with this opportune parameter. As in all assay, we must consider the limits, and the liquid biopsy for these patients, the limit can be related to a low tumor shedding that can be the mask of a false negative test. A negative result does not rule out the presence of an actionable alteration, such as, for example, BRCA2 homozygous deletion. Clonal hematopoiesis of indeterminate potential can lead to a false positive result. But I think that it was probably too much stress at this opportunity because the genes do not overlap. And I think that to avoid these problems, a ctDNA test produced on plasma and parallelly a germinal test or nucleated blood cells could avoid this problem. Obviously, this raises the cost, but I think that the cost of a PARP inhibitor is so high that the cost of a sequencing of blood could be considered very ridiculously low, at least in my opinion.
Yeah. No, I appreciate the views there. So ctDNA liquid biopsy definitely has a role, but we need to acknowledge those limitations. And yeah, the testing in relation to the drug is a fraction of the cost. One thing I did want to ask, and I don't think we'll have time, is looking at that role of the urologist. I know we've touched into this, and one thing that we'll be doing here at Diaceutics, unfortunately, we didn't have a urologist join us today, but we are going to have a conversation with the urologist around this topic, and we'll be posting that to our website as well in terms of that conversation to get all sides of it. Just for time's sake, we've got just move on to the Q&A, and appreciate the questions that have come in. One of the questions I would like to ask you guys, and they would be 30 seconds most, just for timing, is in relation to reporting, what do you see as the critical things that are most useful for you in terms of including in the report to make it as effective as possible? Dr. Attard, I'll start with you.
So first, BRCA, yes, no, other, or the gene name and whether it's altered or not. And if there is no alteration, information on the sequencing. So was there good sequencing coverage? Was there no tumor content? So a pass or fail. And I think the latter is very important rather than solely a negativity. And then, you know, in an appendix, it's very helpful to have extensive information on the test, other genes that have been analyzed, the type of alteration seen. You know, that we can turn to if required.
Okay. Thanks, Dr. Attard. And Dr. Barberis, in your perspective?
Telegraphically, I fully agree with Gert, and I suggest to follow the recommendation for the use of next-generation sequencing for patients with advanced cancer published last year by the ESMO Precision Medicine Working Group. I think that if we follow all these parameters, we could produce an excellent report, very easy to understand, and all the information that a patient needs.
Great. Thanks so much for those perspectives there. So just in our last minute, just to wrap up, I just want to highlight and remind our participants that are on the line of the DXRX network, where there's these lab talks hosted, amongst others, and a lot of different opportunities there for collaboration and engagement. But what I'd like to do is just thank you. Thank you, Dr. Attard. Thank you, Dr. Barberis, for the engagement today, for the conversation around HRR testing. Hopefully it's clear that that future state in that implementation of HRR testing is key for that multidisciplinary approach, and really that need to test for all these patients that can enable the appropriate decisions and conversations to be had, and ultimately benefit the patients at the end of the day. So with that, again, thank you, Dr. Attard. Thank you, Dr. Barberis.
Thank you.
Thank you.
Appreciate everyone attending.
Goodbye.
Thank you so much. Bye.